we just finished talking about obstructive lung diseases. Now we go to restrictive lung diseases. So in restrictive lung diseases, these are a group of diseases that impair the ability of the lung to expand and fill with air. So it's restricted from expanding and filling with air. This is opposed to obstructive lung disease, where something's preventing the lung from emptying the air that's inside the lungs. Okay, and the hallmark here is an increased FE1 to FVC ratio. It's greater than 80%. Remember, what was the normal? Normal was 70 to 80%. Obstructive, what was that? Obstructive was less than 70. And then restrictive would be if it's greater than 80%. So this FEV1 FVC ratio is very high yield to know. Okay, and this is because it's greater than 80% because, first of all, FEV1, how much will that decrease in a restrictive lung disease? First, they're both going to decrease, first of all, but it's not going to decrease that much. There's nothing blocking air from coming out, which is this problem, which is this. So nothing's wrong there. But FVC is how much volume you can expire, how much. It's pretty much a measure of how much air is in the lungs, okay? And, let's go back. And we just said our problem was the lungs can't expand and fill with air, so even if there's nothing blocking you for air from coming out, you can't even fill it that much. So FVC goes down a lot, okay? And that's why, because the bottom goes down more, you get greater than 80% FEV1 to FVC ratio. Now, you can have impaired ability to expand and fill with air either from a mechanical problem or from a pulmonary problem. Okay, so what do I mean by these? What is a mechanical problem? Mechanical problem can either be a poor respiratory muscular effort, because you need your respiratory muscles for your chest wall to expand and for air to come in. But if you have something like polio, myasthenia gravis, Guillain-Barré syndrome, these muscles aren't working. Okay, these muscles don't work, so your chest wall can't expand, air can't come in. Okay, poor respiratory muscle effort. Second is if you have a chest wall, something wrong with the chest wall. Something is wrong with the chest wall. Chest wall itself can't expand. If you have morbidly obese, then your chest wall will have more difficulty expanding. Or if you have a scoliosis, that will impair chest wall expansion as well. So those are mechanical problems preventing expansion of the lung. Now, the other thing is you can have interstitial lung diseases. So the lung interstitium is the support tissue in the lungs, not directly involved in gas exchange. So if you have disease there, especially if you have fibrosis, it's scarring, it's not going to be able to expand very much, it's not going to stretch out and expand, so your lung is not going to be able to expand and fill up with air. So we have a lot of these. We're going to talk more about these in a second. Pneumoconiosis, idiopathic pulmonary fibrosis, sarcoidosis. These ones I just want you to be kind of familiar with. Drugs can cause interstitial lung disease. Goodpasture syndrome, what was that? Remember, what do we say about Goodpasture syndrome? Remember, it's the one that hits the lungs, it hits the kidneys, it has the antibodies against the basement membranes. It can cause nephritic syndrome, a rapidly progressing nephritic syndrome. And then this one, granulomatosis with polyangiitis, aka Wegener's disease. Remember, it's the small vessel vasculitis. It hits lots of parts of the body. It hits the upper respiratory tract, it hits the lower respiratory tract, hence this interstitial lung disease. It hits the kidneys, also causes the RPGN. And then finally, we have hypersensitivity pneumonitis. Okay, so I want you to know a little bit more about this. If you usually see this in a farmer or a bird keeper. So you hear about a farmer or bird keeper with lung disease. It's probably a hypersensitivity pneumonitis. What happens is these guys are going to be exposed to antigens from either the farm, from like hay or stuff on the farm, or from birds that they're taking care of. And these antigens are going to cause a type 3/type 4 hypersensitivity reaction in the lungs. They're going to inhale these antigens either in the farm or from the birds. It's going to go into the lungs. There's going to be a type 3 or type 4 hypersensitivity reaction, and you're going to get a hypersensitivity pneumonitis, inflammation of the lungs from hypersensitivity. So symptoms, you get fevers, respiratory symptoms, shortness of breath, cough, chestitis, and then once you remove that trigger, they're going to get better. Okay, so but really honestly, you see about a farmer or bird keeper with lung problems or a fever, that's probably hypersensitivity pneumonitis, and that can cause a restrictive lung disease. Okay, all of these can cause restrictive lung disease. So now we're going to focus on these three right here. Pneumoconiosis, what is this? This is due to occupational hazards that lead to interstitial fibrosis in the lungs. And what happens is small dust particles will reach the alveoli. Remember that small dust particles can invade. Remember what was the defense process in our lungs? Remember we have the cilia and the mucus that usually traps foreign particles. But it's very small. It can get through. It's going to get all the way to the alveoli. And then we talked about the alveolar cells. We have alveolar macrophages there. And they're gonna phagocytose these foreign particles. They're going to release cytokines, they're going to cause inflammation, and they're going to cause fibrosis in the lungs, and that's how you get restrictive lung disease. Now, there's going to be 4 different ones we're going to talk about. Asbestos is going to affect the lower lobes. So the way you remember this is asbestos is found in the roof, but it's the opposite. It affects the lower lobes, and then the other ones are all the opposite. Silica, coal, and beryllium affect the upper lobes. Okay. So just remember, asbestos is in the roof, but it affects the lower lobes, and then the rest is just the opposite. They affect the upper lobes. Okay, so asbestos is then the first thing. Asbestos, we said, was found in roofing. You can be found in plumbing, and you can also find it in shipyard workers. So that's the one you have to remember, shipyard workers. Otherwise, roofing, plumbing, stuff in the house. Okay, asbestos is found in the house. And we're going to see what features to identify it. So if you have a pneumoconiosis and you see asbestos bodies, these are these golden brown rod structures. Okay, you see this golden brown rod structure, that's an asbestos body. That's going to tell you it's asbestosis. If you do imaging, you're going to see ivory white calcified pleural plaque. That's a key word. Ivory white pleural plaque calcified. That's pathognomonic for asbestosis. That means if you see it, it's asbestosis. Finally, last thing to know about this, for this disease, if you have asbestosis, you have increased risk of both bronchogenic carcinoma and mesothelioma. Bronchogenic carcinoma obviously is cancer arising from the bronchi, and mesothelioma is cancer arising from the lung pleura. Okay, and bronchogenic carcinoma will be more common than mesothelioma. You wanna know that. A person with asbestosis will be more likely to have bronchogenic carcinoma than mesothelioma, but they're going to be at risk for both. Next is berylliosis. So what people are going to get this? I mean, this one's pretty easy to remember. It's just people who mine beryllium and people in our aerospace industry, because those people use beryllium. So beryllium miners, aerospace industry people, they're going to get these beryllium particles, and it's going to cause inflammation, fibrosis, and this pneumoconiosis. And the characteristic feature here is a non-caseating granuloma in the lung and the lymph nodes. So non-caseating granuloma will tell you it's a berylliosis. Next is the coworker pneumoconiosis. Okay, see, this one again, associated occupation, super easy. Coal miners, they breathe in too much carbon dust. Now you're going to see a black lung. Black lung means coworkers pneumoconiosis. And this one is associated with Kaplan syndrome. So what the heck is Kaplan syndrome? This is pretty low yield in my opinion, but it's basically a rheumatoid arthritis with a pneumoconiosis with intrapulmonary nodule. So you see rheumatoid arthritis, you see pneumoconiosis, that means Kaplan syndrome. It's usually associated with the coworkers one. Coworker pneumoconiosis with rheumatoid arthritis. Okay, but the key thing here is the black lung and coal miners. Finally, silicosis. Silicosis, again, super easy. Silica miners, sandblasters. Why do sandblasters get this? Because silica is the most common component in sand. Okay, so you're going to blast out all this silica particles. They're going to inhale it. They're going to get lung pneumoconiosis. Now, these guys are going to have increased risk of TB. That's the one thing to know about these guys with silicosis. Okay, that's because macrophages are going to eat up that silica. For some reason, they're going to become less active against TB. So just to review, asbestosis, berylliosis, coworkers pneumoconiosis, and silicosis are your 4 causes of pneumoconiosis. The associated occupation is pretty easy. Silicosis, super easy. Coworkers, super easy. Beryllium, super easy, as long as you know that aerospace people use beryllium. And the only one, roofing, plumbing, it's asbestos. That's where it's found. It's in your house. The only one I think that's harder to remember is shipyard workers. Shipyard workers with asbestos. Remember that asbestos affects the lower lobes, even though it's found in the roof, so it's opposite, and the rest do affect the upper lobes. Okay, you probably want to know this because it's very testable. And then just remember the bolded stuff. Okay, next we go to idiopathic pulmonary fibrosis. So obviously from the name, it's pulmonary fibrosis, and we don't know why. It's idiopathic. What you're going to see, the way this presents, it's going to be gradual onset shortness of breath. So it's like a slowly progressive fibrosis, so you get a gradual onset shortness of breath. And what you're going to see here, the characteristic is a honeycomb appearance. That's because these bronchi are going to dilate, and eventually they're going to coalesce to become bigger and bigger, and so that's why they're going to look like that. Honeycomb appearance of the lung. Okay, you can see it kind of looks like that. It's kind of gross, so I don't want to look at it anymore, but honeycomb appearance of the lung, gradual shortness of breath is idiopathic pulmonary fibrosis, aka IPF. Finally, sarcoidosis. This one's pretty high yield, quite high yield actually. Sarcoidosis, you're going to see this a lot. It's an immune-mediated systemic disease. Systemic immune-mediated. You're going to see non-caseating granulomas in multiple organs. So that's a very key thing. Non-caseating granulomas in multiple organs in sarcoidosis. And it's the granulomas in the lung that are going to lead to impaired expansion of the lung, hence restrictive lung disease. Remember, we're still all of these things we're talking about all cause restrictive lung disease. So this one is also of unknown etiology. This picture here is the non-caseating granulomas, granuloma. Okay. And the key thing is here is if you see a young adult African American female with pulmonary and systemic symptoms, your answer is probably sarcoidosis. Young adult African American female with pulmonary symptoms. Okay. What are pulmonary symptoms? It's just something vague stuff. Cough, shortness of breath, chest pain. Right? Cough, shortness of breath, chest pain, breathing faster. There's not breathing very well. It's pulmonary symptoms. And a young African American female, be suspicious of sarcoidosis. Now, systemic symptoms. You can have anything. Pretty much any other tissue can be involved because these granulomas can be in any organ. But you can see skin lesions. You can see uveitis, so inflammation of the eyes. And the really characteristic stuff is the diagnostic. So you're going to see bilateral hilar adenopathy on chest x-ray and CT scan. So you see here, this is enlarged hilar lymph nodes. This is normal. You see very small, the present but small. These are big fat lymph nodes. That's bilateral hilar lymphadenopathy. It needs to be bilateral, and it needs to be the hilar lymph nodes. Okay. You add this onto the young African American female with pulmonary symptoms, 100% sarcoidosis. The other things you're going to see here is elevated serum ACE. Remember, ACE is the angiotensin converted enzyme, and also you're going to see hypercalcemia. Now, the thing I want you to know about this is PTH independent. Okay, it doesn't act. There's no increased PTH here. What's going to happen is macrophages are going to increase activation of vitamin D, and the vitamin D then is going to lead to increased absorption of intestinal calcium, and you're going to get hypercalcemia. So it's PTH independent. That's testable. Okay. Finally, the way you treat this is often it may self-resolve. Otherwise, it's an immune disease, so you give them steroids. Okay. So this one's how you. But basically, all of these were restrictive lung diseases. Restrictive lung disease. What would you see on FEV versus FVC? Remember, it's greater than 80%. Restrictive lung disease. Lung is unable to fill with air, and so that's the problem. Right? It can be mechanical or from the interstitial lung. And we just talked about 3 of the causes of the interstitial lung restrictive lung diseases. Now I want to compare and contrast restrictive and obstructive lung disease a little bit, and we're going to do that through the flow volume loop. You're going to see that you can get tested with this too, so you want to know this. Flow volume loop looks at the air velocity, airflow, this is air velocity, through inspiration and expiration. So expiration is the top part, and inspiration is the bottom part. So when you expire, flow is going to be positive because it's going to be coming out. When you inspire, it's going to be negative flow because air is going to be going into the lungs. Okay. Now, first of all, we want to look at the volumes. Look at this thing. This x-axis is the volume, and if you want to notice, this one's kind of weird because higher volumes is on the left. So for some reason, they do a higher volume on the left. And the thing you want to know is which one is going to have a higher volume. Is restrictive lung disease going to have high lung volumes? Remember, the whole definition of this disease is it doesn't fill up with air, so it's going to have low lung volumes, hence why it's on this side of the curve. And then obstructive lung disease, you can't get that air out, there's air trapping, so it's going to be on this side. It's going to be high lung volumes, left side of the curve, and this is all normal. Okay. Now, let's focus on the obstructive first. Obstruction decreases flow of air through the lungs, right? So that's why you get decreased amplitude here. Remember, this is flow. Height is flow. So there's decreased amplitudes because there's obstruction. And then because there's air trapping, increased total and residual lung volumes, there's going to be a left shift to this. All this volume is going to shift left because there's going to be increased air volume. What about restrictive lung disease? Is there going to be, how's the airflow going to change? Restrictive lung disease is going to be, the airflow also decreases. You see, it's not as decreased as obstructive, but it is still decreased. And finally, again, we talked about how the volume shifts to the right because there's less volume in the restrictive lung disease. Okay, that's basically what I just talked about. So that's it for our restrictive lung disease as well as a little recap of obstructive lung diseases.